What we're going to talk about today is the single visit CEREC crown cementation considerations. We're going to talk about basically two different types of cements that I like to use with regards to CEREC. And the first type is a self-etching resin cement, which is we're going to talk about Maxim Elite here. And then we're going to also talk about NX3. Both are from Kerr. Both are great products, and we're going to talk about basically what are the indications that I like to use when using these cements. Just a little bit of background about myself. I am in private practice in Tarzana, California. I'm a founder of CERECdoctors.com, which is a CEREC training website. We've had several thousand members on the website, and we basically just train people how to use their CEREC machine through the use of the website. I'm also on faculty at the Scottsdale Center for Dentistry, and if you hadn't had a chance, visit www.scottsdalecenter.com, and you'll learn more about the center. There's some great faculty there: Gordon Christensen, Dr. Frank Spear, Dr. Cliff Ruddle, many others, and it's a wonderful place to learn. So now on to our topic at hand. We're going to be talking about the different types of cements, and we basically have two different categories. One is the traditional resin cements. NX3 is the one we're going to concentrate on today. Some other examples of this would be Variolink 2 from Ivoclar, Calibra, Reliex from 3M, and then we also have the self-adhesive resin cements, and these include cements such as the glass ionomer cements, our resin-modified glass ionomer, polycarboxylates, zinc phosphates, and now the new category, which are the self-etching resin cements. And typically what happens is that usually the cements on the right side of this chart, the self-adhesive cements, are easier to use. You simply mix them, you apply them. You don't have to go through tedious bonding steps with these types of cements. With the resin cements, the traditional ones, you usually need to place some sort of etch on the tooth, on the enamel and dentin. You can place a bonding agent on the tooth, and then you apply your resin cement. The main difference is that while the traditional resin cements are more difficult to use, they usually impart a higher bond strength. Whereas the self-adhesive cements, you don't have as much of a bond strength, and so you need to rely on traditional retention and resistance form. And so when I'm using these cements for CEREC, and for CEREC I wouldn't use a zinc phosphate, polycarboxylate, or any of the glass ionomer cements. We're only going to concentrate on our self-etching resin cements, which is the Maxim Elite in this category. And so when I have a flat top type preparation, I want to get as much bond strength as possible. When I have traditional retention and resistance form, then I don't need to rely on my bond strength as much, so I can stick with an easier protocol. If you look at the bond strengths of the NX3, and this is with the Optibond Solo Plus or the Optibond All-in-One, basically we are in the 30 plus megapascal range. And our goal whenever we're trying to bond something should be to try to get a bond strength between 25 and 30 megapascals. When we're at 25 and 30 megapascals, if you were to take two pieces of tooth structure, two pieces of teeth, and bond them together and break it apart, chances are you're going to break the tooth before you break the bond. So that's why we want to be in the 30 plus megapascal range. And you can see with to dentin, when we're light curing these restorations, I mean we're right there where we want to be with the bond strength. Conversely, if you look at some of our self-etching resin cements that are on the market, Maxim Elite has the highest of these bond strengths, but these tend to be not as strong. You can see the Unisem is in the 7 megapascal range. The old Maxim self-cure is in the 8 megapascal range. So the Maxim Elite has definitely been improved, and so we're getting to that 25 to 30 megapascal range. But because this is non-assisted, there's no etch, there's no bonding agent, we're not as high, but certainly you've got plenty of bond strength as long as your retention and resistance form is there. Because if you think about it, gold crowns tend to stay on forever on our teeth because we prep them with retention and resistance form. And zinc phosphate doesn't have any bond strength. It's 0 or 1 megapascal. So 21 is fantastic, but it's not as good as the previous, the NX3, when you're using a bond strength under it. So we'll talk about when we use one versus the other. The nice thing about the Maxim Elite is, our topic today is the Vita blocks. we're at 30 megapascals, so the bond to the materials that we're bonding the tooth structure to is fairly good. We're again in that 25 to 30 megapascal range when we're using the MaxSem Elite. So this gives me the confidence that I can use this cement fairly routinely in my practice and not have to worry about debonds or anything of that nature. The one thing that we do worry about with dual cure resin cements is that over time these cements will discolor a bit. So if you look at Reliex, Calibra, Verilink, all of them over time will lose a little bit of color stability after aging. The NX3 has shown to be a fairly good cement, and this is what I've experienced. But regardless of the fact, in the posterior, this little color shift shouldn't make that big of a difference. Where it's critical is in the anterior. You don't want to use a dual cure resin cement, for example, under veneers, where the cement plays a major role with regards to your the final color. So you want something that's stable. So I would recommend you only use a light cure version of NX3. And it's available where you can use the light cure version or the dual cure version. Stick with the light cure version for anteriors. For posterior, you have the confidence that this material isn't going to change color over time, although your porcelain should be thick enough to compensate for that. So looking at two different types of preparations, here we have the preparation on the left, a little bit difficult to tell from the angle, but we've got a traditional prep with shoulders. This is a replacement of an existing crown. I've got 4 or 5 millimeter, 6 millimeter walls on the buccal and lingual, so I have no problem. I can use any type of cement here. So the MaxSem would be ideal in this situation because I simply put it in the crown, seat the restoration, cure it, clean up, and you're ready to go. Bond strength here is not as critical. Yes, you want it to be high, but we're not relying solely on bond strength to retain our CEREC restorations. We're going to rely on traditional retention and resistance form. Conversely, on the preparation to the right, this is basically a flat top preparation where we don't have shoulders all the way around. You can see how much more enamel we're able to preserve this way. So in a situation such as this, I'm going to rely on my adhesive bonding to maintain that restoration. So I want a bond strength that's going to be as high as possible. The NX3 with the Optibond Solo Plus is going to work out very well here because it's higher than my threshold of 25 megapascals, and it's going to retain my restoration. The blue restoration you see here, this is the Emax CAD material from Ivoclar, and it's in a blue state because it's a bit softer, and you put it in the oven and it retains its final color after going through about a 25-minute crystallization cycle. And the reason we do it in the blue is just less wear and tear on the milling unit. So here's another example of a preparation where I don't have traditional retention and resistance form. It's basically a flat top with a shoulder on the buckle for aesthetic reasons. But because I don't have to deal with temporaries with CEREC, I don't need to retain my temporaries. So we prepare the teeth in trying to conserve as much enamel as possible. And so you can see on the lingual, there's no shoulder. We're keeping that margin high and dry. It's going to be very easy for the patient to clean, and we're able to preserve a ton of enamel in that lingual portion. Whereas a preparation like this, we've got plenty of retention and resistance form. Again, MaxSem Elite, it's going to be a lot easier for me. I don't have to etch and bond and go through all of my steps in that situation. We'll see this case towards the end of the broadcast, where I'll walk through step by step, how we do it. And but for something like this, squirt some MaxSem Elite inside your crown, seat it, you cure it, and you're ready to go. We've got plenty of retention and resistance form built into the preparation. Where we're not relying strictly on our adhesive bonding to maintain that restoration. So that's why I like to have two different cements on hand, and I can either use the NX3 or I can use the MaxSem. And basically the MaxSem is self-etch, self-adhering. There's fewer steps. It's it's dual cure. You do not need to refrigerate these, which is nice. They come in a bunch of shades, but it's really for posterior restorations. I basically stick with the translucent cement. I find that works well to blend in my margins because typically my margins are high and dry. So what I want to do now is go through an NX3 case where we walk through step by step how we use this particular cement. And I want to go through each each step of it. We're going to start with a CEREC case. It's got a very easy cleanup. I like this cement because the cleanup, which is one of the big complaints of clinicians, is that this cleanup is difficult. You know, you start curing that restoration and it becomes very difficult to remove the interproximal cement. And sometimes you don't pick it up and the patient comes back for a hygiene recall and you look you know, on a bite wing x-ray and there's a little piece of cement caught there. So I'll walk through why I like to use this. So again, it's got strong adhesion, it's a good cement, and you can use it with many different types of bonding agents. So here's a clinical case that we're going to look at. This patient presented with a cracked tooth syndrome, and you can see this is tooth number 19 here, and he had a fracture on the buccal, and there was also an existing amalgam on the previous tooth. Now with CEREC we've got two different modes. I can create a tooth from scratch, or I can copy what is existing in the patient's mouth. You can see in the pre-existing condition there is a little bit of an occlusal issue, meaning this second molar is not in proper occlusion. Now the patient is not going to go through ortho or anything like that. This is how his occlusion is, so I want to maintain this occlusal relationship with him and copy it as precisely as I can. So I'm going to use what's called the correlation technique. Basically, I'm going to copy this tooth and recreate it with my CEREC while preparing it for a full crown because of the cracked tooth syndrome that's present. So the first thing I want to do is we're going to go ahead and powder the restoration. The reason we powder it is because I want to capture the image before I start cutting on the tooth. And with CEREC you do need to place an opaquing medium, and in this case which is powder. And what that allows us to do is capture, the camera can see the restoration, can see the tooth structure. Enamel, dentin, amalgam, you know, soft tissue, basically all of these different materials that are there, that are present in the mouth, they all reflect light a little bit differently back towards the camera. So what the powder does, it creates a uniform medium that the camera can see. You know, powdering is one of those things, you know, you do it once and you pick it up. It's very easy and quick. You simply take a powdering device, spray the teeth, and this is about a 5 to 10 second procedure. Just, you want to make sure everything that you're going to capture in the camera that you can see easily is covered with powder. The next thing I'm going to do is, because this is going to be a full coverage restoration, because of the cracked tooth and the symptoms that are present for the patient, we're going to create our occlusal depth. Now, the number one reason that restorations fail, all ceramic restorations fail, is that you know, they're under-reduced. You need adequate thickness of porcelain. And so the CEREC technology gives us feedback, and it tells me exactly how thick I am at every step of the way on the restoration. But to get that thickness, I need a proper 2 millimeters of reduction. So I'm going to take what's called the occlusal router burr, and you can go to occlusalrouter.com, and it's a 2 millimeter depth cutting burr, and we simply make 4 or 5 or 6 very quick depth cuts in the occlusal table of this tooth. And I want to follow the anatomy of the tooth. I don't want to just go straight across. If there's any pits and fissures, I want to go down, so I'm 2 millimeters reduced on the occlusal at all times. Once I create my occlusal depth cuts, the next thing I'm going to do is I'm going to level my occlusal table. And you can see the crack, that's just the remnants of the crack that are present on the distal. That's what was giving the patient discomfort. And certainly if the patient wasn't symptomatic and we didn't verify the cracked tooth syndrome, I could have done a more conservative preparation, but because of the symptoms we had to do a full coverage restoration. And so we very quickly level the occlusal table, and what that does, it gives me a uniform 2 millimeters of reduction. And once I have this, then it's just a matter of determining how I need to finish my preparation. Obviously we need to remove all of the amalgam that's there. I always like to get interproximal separation because it allows me to create a proper emergence profile and allows me to image the case much better with my CEREC restoration. And so once I have removed all the existing restoration, and once I've you know, done my final preparation, here is basically my final prep. And you can see not much traditional retention and resistance form, just a little bit of the shoulder on the buccal just to lower that that margin just a touch so we can blend it in. We're still 3, 4, 5 millimeter super gingival in this area. But on the lingual, it's just basically flat top, and there's no reason for me to reduce, put a shoulder there, because I'm going to remove that enamel. And enamel is key, and anytime I can preserve enamel on the tooth, we're going to have a much better prognosis for the tooth. So when we finish our preparation, again, I've got separation from the adjacent teeth because I've taken my margins interproximally almost down to the gum line, and I've used a laser in this case just to remove a little bit of gum tissue so that I can have good clean access to my margins. The preparation is finished, and we're going to go ahead now and powder the preparation one more time, and then we're going to image it. So I've got one image of the pre-op situation and one image of the preparation. We designed the restoration with the CEREC, and in our practice we pretty much stain and glaze everything that we do. I would say everything except a small little inlay, and this is delegated to the assistants, and sometimes they put a little too much cavity in the tooth, and the patient wants to take the brown stuff off, but we try to keep it very subtle. We've put a little bit of brown stain in the central pit and fissure, a little bit of white around the periphery. That gives the appearance of decalcification, and a little bit of blue also towards the incisal gives the appearance of incisal translucency. And this is just a surface stain, and in a normal situation this is going to take about 7 or 8 minutes in the oven to bake this stain onto the crown. So while the oven is working and glazing our restoration, we go through the process of getting our tooth structure ready to bond to the crown. In this situation, I placed a rubber dam. Typically, I'll use either an isolite or a rubber dam. Both are great at isolating the operative field, but we used a rubber dam. You want to make sure you get all the powder off and just make sure the surface is clean. If there's any powder contamination, it can lead to a little bit of sensitivity post-operatively. But we get our area isolated, and now I'm going to go through my bonding steps. So the first thing I'm going to do is I'm going to try in my restoration. So here it is out of the oven, and up to this point I have not tried in the restoration in the mouth, simply because I'm very confident with the fit of the restoration, so I don't need to go ahead and verify until after we're ready to bond the restoration in. I'm going to go through a total etch procedure where we etch the tooth completely using phosphoric acid, 15 seconds on enamel, about 10 seconds on the dentin. Dry it off completely, and then we're going to apply our Optibond Solo Plus. I like the Solo Plus because it comes in the unidose packages. I've been using this bonding agent for years, and it's worked very well. And I'm applying it liberally all over the tooth and letting it soak in. You don't want to air dry it right away. Give it a good amount of time to let the solvent penetrate your dental tubules, and then blow off any excess that you may have. And once you blow it off, our surface is ready to be bonded to, and at this point we go ahead and make sure it hasn't pooled anywhere, and I cure it to the tooth, because anytime I can pre-cure my bonding agent, I'm going to have higher bond strengths for my restoration. So our tooth surface has been prepared. My porcelain piece, we tried in the crown, we etched the inside of the porcelain with hydrofluoric acid, and then we apply the silane. Kerr silane primer works very well. Typically you have to apply a silane and then you apply a bonding agent after that. With the silane primer, it combines those two steps into one step. And because of the preparation is fairly flat, the crown is a little difficult to hold, I usually will take my cement and apply it directly onto the tooth. And usually we're very conservative with the amount of cement, but in this case you don't want any voids or porosities, because when you seat that restoration you want cement covering the entire preparation. Put the cement on and then go ahead and seat the restoration, making sure that there is cement coming out from all margins. At this point what we'll do is we'll wait about 10, 15, 20 seconds, something in that range. Let the cement gel cure. It starts a chemical reaction, it starts to cure and set up on its own. Either myself or my assistant, we hold down the crown and then we start flossing, because interproximally that's the biggest area where people have trouble, is they have cement interproximally. So the cement is starting to gel up a little bit. we hold down the restoration and we floss the distal, and then while maintaining the pressure, we floss the mesial. And once you start flossing, there's a chance you may have a little bit of bleeding or a little bit of contamination. So you've got to make sure that this restoration is held down and it does not move, because you don't want any cement to get contaminated interproximally. So very gently floss. Don't force it down. Don't shove it into the papilla. Just be very gentle with it. Once we have cured, or once we have flossed, I should say, we go ahead and light cure. And typically what I'll do is about a 5-second light cure on the buccal and lingual, and just to get the cement to set up, and then all the big pieces that might be sticking around, I take a scaler and just kind of flick them out. Once those areas are clean, we'll go ahead and remove all of the excess cement and finish our cleanup process, and then cure the restoration fully. So here is the finished cement. This is the immediate post-op, and you can see that we've got a little powder remnant, and there's a little bit of tissue irritation from the cementation process, but we're done. I mean, it's a very quick and easy procedure. The key is that once you push this restoration down, don't let go. Keep it down, floss interproximally, and then do your final curing, because if you let go and that restoration moves, you're going to get blood that comes underneath, and then you basically have to start over, clean up, start all over. The cement has a very nice working time in that it's not going to set up on you quickly, but you do have to be somewhat aware of any overhead lights. If you have a powerful overhead light, or if you have a light on your forehead, you have to be careful that you're not shining that on the cement before your restoration is fully seated, because you can cure that cement prematurely. Ask me how I know. I've done it once, and I'll never do it again. I was trying to take pictures and had the light on, and by the time I got to the final seating of the crown, the cement had already set up, and we had to start all over again. So good working time with the cement. Fairly easy to use, but it is more steps than something like a Maxim Elite, where you simply would push the cement into the crown and then go ahead and seat the crown. But it's not that difficult once you get through the process. You have to decide what's more important. Is it the high bond strengths that you want, requires a little bit more work, or do you want the ease of use where you don't need that high bond strength because it's available within your preparation? You've got that retention and resistance form built in. Here is a follow-up, a few weeks later of the restoration. Blends in nicely. Again, the staining and glazing, that's strictly up to you and your staff, however you want to do it. You can put a lot in there, you can put a little in there, but the patient was completely asymptomatic after this, very happy with the end result, and it looks good, it blends in. So you can make these CEREC restorations look very aesthetic. Takes a little bit of effort, or you can put white blobs in patients' teeth if you don't want to take the 5-10 minutes it takes to stain and glaze these restorations. So just to recap, flat top preparation, very little traditional retention or resistance form. You want to use the highest. You want to use the cement with the highest bond strength. So NX3 with an Optibond Solo Plus would definitely fit the bill here. Does take more work, but it's definitely worth it. Here's another example of we've got a crown with a fractured buccal cusp. There's some decay on this tooth that has occurred, and we treatment planned this case for a full coverage restoration. And because we don't have to put on a temporary, because the patient doesn't have to come back a second time, we want to maintain our enamel. We want to save as much enamel as possible in doing a case like this. So we go ahead and do our preparation. Again, on the lingual, there's no reason for me to put a shoulder. Look at how much enamel I'm able to save. Interproximally, I always take it down to the gum line because I want that nice emergence profile. And on the buccal, you have to decide if this is an aesthetic zone, then maybe take it down to the gum line. If it's not an aesthetic zone, you can certainly leave your margin higher. This patient kind of had a big lip line, very aesthetically conscious, so we took it about 1 millimeter or 2 above the gingiva so we could get nice aesthetics that way. In this case, I've packed a cord, and I use both cord and I use a laser, so it's really a matter of preference. It just depends on what you feel like doing that day, or if my laser's not available, maybe my associate's using the laser, then we'll pack cord. I find them both to work equally well. Laser is certainly more convenient, but by no means is it mandatory for CEREC restorations. And here is the finished restoration. This is again stained and glazed. The total time for something like this is anywhere from 1 hour to 1 hour and 15 minutes in our office. And patient had veneers done about 10 years ago. You can see the tetracycline stained teeth on the adjacent teeth, and we simply are just trying to blend this restoration in with the adjacent teeth. Now with Maxim Elite, where would I use something like this? I'm going to show a couple different examples of this. Again, the bond strengths are not as high, but certainly the cement is a lot easier to use, and in certain situations you don't need super strong bond strengths. A canine crown, full coverage crown on tooth number 6, you're going to have a 7 to 8 millimeter long tooth. There's really no need for super high bond strengths, and this Maxim Elite would be very appropriate in a situation like that. This is an interesting case. This is a patient that's going to be having a full mouth reconstruction, but currently they're not quite ready to proceed yet. The teeth are really worn down. So with my CEREC restoration, he's got a missing tooth here, and he just wants something temporarily. So what we did was we prepped the teeth, and we're going to do a bridge for him utilizing the CEREC. And you can't do full contour permanent bridges with CEREC, but you certainly can do full contour temporary bridges. Just because there's no material available that's strong enough that you can build to full contour that's aesthetic enough. It can certainly mill out frameworks, but then you have to stack porcelain on top of that. That's something I'm going to send to my laboratory. So we take a bite registration. This is a virtual CAD bite from Ivoclar. This doesn't need to be powder, and this helps me determine my occlusion with the case. And here's a screenshot of the bridge being designed. The different colors on the occlusal surface of these restorations tell me with how much intensity I'm having occlusion with the opposing dentition. Here's the temporary bridge that's being milled out. The material is called the Vita CAD Temp, and you can do, it's a 40 millimeter block, so however many units you can fit in there, you can mill out with the CEREC. And so we go ahead and cement this. Now, initially we cemented this with temporary cement, and then the patient came back when we found out that it was going to be, a little bit longer than what we had anticipated that he was going to have the temporary bridge in place. It was going to be about a year or so. So I thought, instead of taking a chance that the temp bond material that was used here, that the bridge may come loose, we ended up using Maxim Elite, and it's worked out very well for the patient, and he's when he's ready to proceed with his full mouth rehab, we'll be able to simply cut this bridge off. So for a long-term provisional, Maxim Elite will work very well. Realize, when I say long-term provisional, I do know that I will be cutting this bridge off completely, because it's going to bond that bridge to the tooth structure. Implants is another area where I use Maxim Elite. It's very easy to do. So this is a case where the patient had 2 teeth that were splinted. She lost the posterior one, so we're taking a fixture level impression. This is the Nobel Biocare system. And we're going to take a fixture level impression and pour up a model. So most of my implants I do in 2 visits, simply because I just find it easier and more accurate, because usually the implants are buried deep below the gum tissue, and I just find it easier to access those implants with a fixture level impression. So here what we're doing is we're just taking some denture reline material, squirting around the abutment, and we pour up stone, and this creates my soft tissue model. And you can use a metal abutment if it's not an aesthetic zone, or if it's an aesthetic zone, we're going to go ahead and use a zirconia abutment. But we can take off this little soft tissue plug, and what ends up happening is it gives us true access to our margins. And so now I just simply scan this just as if this was a crown in the tooth or crown in the mouth, and we just make the restoration off models. And so we mount it on our articulator, we prep the abutment as needed, and then just scan it, and we have our restoration in the mouth, in the model. And so we are able to see all our margins, and designing a restoration on an implant crown is very similar to designing a restoration on top of you know, a tooth. It's just our substructure is a little bit more narrow, so you have to compensate for that. But the software is very easily able to design my restoration, and I can look at it from different angles. I can adjust the occlusion as needed. It's a little difficult to see right here, but it says height of fissure on the bottom right corner of the screen, and that tells me how thin the thinnest area in my central groove area is. In the central groove area, you want to be at least 1.5 millimeters thick, and the software again gives you feedback that you're thick enough. Now the material we're going to be using in this particular situation is the Emax CAD material from Ivoclar, and this is a strong enough material. It is a porcelain, but it's a special porcelain. It's basically their Eris material, whereas a regular all ceramic restoration is going to be in the 130 to 140 megapascal range with regards to strength. This is about 360 megapascals in strength, so quite a bit stronger. And according to the manufacturer, it's strong enough where we can traditionally cement this. So I could use a glass ionomer cement if I wanted to. But it's blue because it's a softer state, so it allows us to mill it very easily, and then we go through our stain and glaze cycle. So it's a little bit strange when you're first doing this to glaze and color the restoration you know, on a blue block, but once you put it in the oven, then it gets its final color. Here, patient comes back, we torque down our abutment and just put some Maxim Elite inside the crown, seat it, and I've bonded this porcelain restoration to the tooth using a resin cement. I'm not going to get a huge bond between the metal and the resin. I know that. I'm relying more on traditional retention and resistance form to retain this particular restoration, but it allows me to do the procedure very, very quickly. I like using the Maxim here because it's still a stronger cement than what I have with regards to my glass ionomer. And so it's just another clinical indication for the Maxim Elite. Finally, let's take a look at our last case here. And what we have is a tooth that's broken down. This is a patient that had endo done, and the endodontist placed a temporary material in there, and this is how he presented to our office for restoration. Whereas the first case I showed you guys, we had plenty of retention, we had plenty of enamel. You'll see by the time I work on this case, there's not much tooth structure left. And whereas originally I had something good to copy, in this case I don't have anything good to copy. So what we're going to be doing is using the database technique of the CEREC, where we're going to design a tooth from scratch. This is not the type of anatomy or contours that I want to copy. So I'm going to create a tooth from scratch, and the CEREC allows me to do this very, very easily. We take a bite registration. In correlation, I don't need to take a bite because we're simply copying what's there. But here, I want to take a bite registration because I want to be able to get my occlusion. So when I seat my crown, I have very little occlusal adjustment, if any, that needs to be done. So the bite allows me to capture my occlusal information. And just like the tooth, we need to powder this bite. So we take our spray and very quickly and easily just powder the areas that we're going to be imaging. You want to powder not only the bite registration, but you want to powder the adjacent teeth as well. And depending on the material, this I believe is just a blue mousse material. Depending on the material, you may not need to powder it. Some bite registration materials are made for CAD/CAM where they don't need to be powdered, and others are not. So this does need to be powdered, so we go ahead and powder the quadrant. I take my images. When we clean out the decay and the temporary, this is what's present in the tooth. And it doesn't appear that there's much left from this angle, but by the time I go in, I do a build-up and prep my tooth. Here is my preparation. As long as I've got healthy tooth structure well beyond my buildup material, I'm very confident in this case. If I don't want my buildup material to go down to the gum line and then just start my crown, because that's going to not be a successful case. That's going to fail prematurely. So we do our traditional preparation, trying to get as much of a ferrule effect as possible to get healthy tooth structure beyond our buildup. I go ahead and pack cord, use a laser, whatever you need to do to get isolation. And then we go ahead and, in this case, we're packing a little bit of cord. I like to use this thin little instrument called the IPC instrument, and pack the cord, powder, and then here is the immediate post-op of the crown tried in. And here we are. I believe this is 6 months later. You can see the nice tissue response on this particular patient. The aesthetics, everything blends in nicely, and this is a situation where we use the Maxim Elite. Really, when I've got traditional retention resistance form, let's use something simpler. Don't need to etch, don't need to bond. I've got approximately 21 megapascals of bond strength with the Maxim Elite, and I simply place the cement inside the crown, seat it, clean it up, and we're done. So you have to weigh ease of use versus bond strength. You can certainly get higher bond strengths, but you know, you're going to have to go through more steps, and you can cut down on those steps, but you're going to sacrifice bond strength. So it's good to have, you know, multiple cements on hand. There is no right or wrong here. Both cements will work in the appropriate situation. Both are very good cements, and you just have to know when you would use one over the other. Finally, for something like this, if I'm doing a veneer case, I don't want to use my Maxim. This is something where I'd use the NX3, and I'm going to use it with just the light cure version. This patient had some dark staining on her teeth, some tetracycline staining, and we were going to try to lighten as much as possible. And earlier I talked about doing light cured cements only for the anterior for, you know, thin restorations such as veneers, because I don't want that color to fade over time. You can use the NX3 as it's been shown to be color stable, but I still recommend you use just the light cure version of that cement. Now, the first question is, do you use one bottle silane or two bottles? That really depends. You always want to use fresh silane. If silane is left to expire and you get bad silane, it can actually ruin your bond strength. The idea of silane is to increase the bond strength between the porcelain and the resin, so it needs to be fresh. So if I'm using a one bottle silane, something like a Kerr silane primer, I make sure that after a certain period of time that we don't have it just sitting in a drawer and 6 months or a year later, you know, we use it. We use it and then we throw it away after, you know, if it's been sitting out too long. I don't like to take a chance. Anytime that you can use a 2-bottle silane, you're going to get better bond strengths for sure, because it's going to enhance the bond, because that fresh silane is going to be better. But that doesn't mean that one bottle silanes are no good. It's you know, it's really a matter of preference. The next question is, I noticed that you prefer doing a flat occlusal surface. Although this will reduce a little bit of the resistance form, please give us your comment. I think I've answered that. If I didn't answer that appropriately, please don't hesitate to ask again. But again, my idea is that as long as I'm using a cement that can retain that restoration on a flat surface, we are more than happy to just do a flat restoration. There's no reason for me to put unnecessary shoulders and retention and resistance form on these restorations if my cement is strong enough. I'd rather preserve that enamel, you know, whenever possible. So, you know, flat tops are fine. I do them all the time. I prefer them to doing traditional retention and resistance form, simply because you know, I can preserve enamel whenever possible. So any other questions with regards to okay, the question is, can you use correlation in the new mode with CEREC? Yes, correlation is available with the new I'm assuming you're asking about the software version of CEREC. You can absolutely use correlation with the new software version. There is a mode called the master mode and the standard mode. Standard mode is a simplified version of the CEREC where it doesn't have all of the tools available, and correlation is not available in that, but you simply click on Settings, Master Mode, and it takes you to the Master Mode, and correlation is available there. The next question is, what is the best cement for Procera, and do you etch it and use silane? Procera is a zirconia restoration, and then porcelain is stacked on top of that. So basically, because the zirconia is so strong, think of it as a PFM replacement. Zirconia can be etched and you can bond to it, but it's very difficult. Most people recommend that if you are doing zirconia and you're trying to bond to it, that you incorporate a traditional preparation. Think PFM when you're doing zirconia. So Procera, if you're doing a Procera, you don't want to be doing flat top restorations with Procera. You're going to want to do a traditional 360-degree shoulder or chamfer, and then use, in that situation, Maxim Elite would be very ideal for a situation like that. You're not going to really, you can etch and bond it, but the results are very very inconsistent with that. So the question is, can you summarize your indication of which cement? Very easy to do. If you have traditional retention or resistance form, a good example would be a full crown on tooth number 6, the canine. Maxim Elite will work just fine. If I've got a flat top on tooth number 19, the lower first molar, then I want to use a cement with a higher bond strength. In that situation, I would use NX3. Inlays and onlays, I would lean towards NX3, because sometimes, especially with all ceramic, you don't necessarily have that retention and resistance form that you do with gold, because our preps are so divergent, whereas with gold they're more parallel. Implants, where you can't really bond to the abutment, Maxim Elite would work great. Veneers, I would use the NX3. You don't want to use a dual cure cement for veneers. So hopefully that answers your question with regards to the summary. Just if you're in doubt, if you feel that there's not enough traditional retention and resistance form, lean towards the NX3, where you're using a separate bonding agent to increase your bond strengths. If you feel that, you know what, this is, I'm replacing an old PFM, and there's 6mm walls here, the Maxim Elite will work just fine in a situation like that. Next question is, when using Maxim Elite, are you still etching and using silane in the crown? No, you don't need to etch the tooth, but you do need to prepare the porcelain surface. So if I'm doing a CEREC, for example, and it comes out of the milling chamber, we try it in, and I'm going to use Maxim Elite in that situation, I don't need to do anything to the tooth surface, because the cement is going to take care of that. But with regards to the porcelain, I do have to use my porcelain etch, my hydrofluoric acid etch, and then apply the silane, and it's approximately 60 to 90 seconds for each. 60 seconds for the porcelain etch, and then 60 seconds for the silane inside the crown. The etch we're going to rinse off, and then the silane we're going to air dry. And research has shown that if you're using a silane, and if you have like a warm air dryer, ADEC makes these warm air dryers. If you can dry your silane using warm air, it helps to increase the bond strength. It's not going to be a significant difference, but every little bit that we can get, it's going to be better for us. Any other questions? I don't think I missed anything, so if that's it, I hope you guys, well, hang on, here's one more. Tooth number 19, with the cracked tooth syndrome, why did you not do a traditional onlay? It looked as if the crack was not deep, and this is one of those clinical situations where the patient was just having quite a bit of pain, and had I done a traditional onlay, I certainly could have. I just didn't want to take a chance with it. I just felt that a full coverage restoration would have been more appropriate in that situation, certainly more predictable. But we could have done a traditional onlay by just covering the buccal, but the patient was having fairly fairly severe discomfort for a week or two, and just on diagnosis we decided to go with the more comprehensive approach. But can't argue with the fact that we could have done a more conservative restoration. I don't disagree with that at all. So here's my contact information. If you have any other questions or comments, my email should be visible on the website. please don't hesitate to email me. I'm fairly good with email. Happy to answer any questions for you guys. And if that's it, take care, and we will talk to you soon. Thank you very much for participating. Bye-bye.